Well, good morning, everybody. It's lovely to have you join us today. My name is Bronwyn Edwards. I'm the CEO of Roses in the Ocean, and with me is Carrie Lumbey. Want to introduce yourself, Carrie?
Hi everyone, I'm Carrie. I do some facilitation work with Roses, and I'm also a lived experience member of a regional suicide prevention collaborative in the Illawarra Shoalhaven, and we've just completed the co-design of our safe space in our local LHD.
So thanks so much for joining us. I'll just share my screen now, and we will provide you with the presentation and overview of the co-design process so far with our health professionals in the Nepean Blue Mountains region. And then at the end, there'll be some time for questions if any of you have them. So just bear with me while we share screen at the moment. Lovely. All right, so first of all, I'd like to acknowledge the traditional owners of the lands on which we're all meeting today, but in particular to the Darug, Gundungurra, Wiradjuri people of the Nepean Blue Mountains region. So we pay our respects to their elders past, present and emerging. I'd also like to acknowledge people with a lived experience of suicide. For those of you who've joined us here on this live webinar, thank you for bringing your insights and wisdom to the co-design process, and to our health professionals, many of whom we know have a lived experience of suicide also, and that all of you are impacted by suicide throughout your work. Thank you so much for being with us, and of course we acknowledge all people with a lived experience of suicide right throughout your Nepean Blue Mountain region. So today we're going to do a quick little recap on the process so far, and then share with you the outputs from the health professional focus group conversations. So on the left here of the slide, you'll see the overall process that we're undergoing in this co-design of an alternative to ED safe space. Hopefully you've all had time to watch the orientation webinar and read through the information pack that pertains to this process. And if you haven't, you'll be able to find links to those on the Nepean Blue Mountain landing page on the Roses in the Ocean website, which we'll give you the link to at the end. So I encourage you to have a look at those and have a read if you haven't already. So to date, we have undergone a series of small group, focus group conversations with people with a lived experience of suicide from the region. And we've also had some time with them as a whole group. And then the focus of this particular feedback loop is, of course, the focus group conversations that we've held with health professionals from the region. So the purpose of today is to provide this context for you of the actual co-design process. Make sure that we've really heard what you've said. We want to make sure that we've captured what's been shared during the co-design in those focus group conversations with you, and gather broader views and experiences. So after this webinar, this will be recorded. We will ask everyone on here to share it as far and wide as you possibly can with other health professionals in the region, and ask them to watch this webinar, have a look at where things are at with the co-design process, and then complete the accompanying survey, which will also be on our website. Really important that we get as many people from the community tuning in and having their say and contributing to this co-design process. So that would be great. We want to explore what's missing so far, and out of this feedback loop and the one that we did just a couple of hours earlier, reporting back on the lived experience output so far, all the input that comes from those people who've taken part already, if they need to hop online and do that survey again, if they've got other things to contribute, that's great. But also to all those other people in community who weren't in those small focus groups. Once we've got their input, we will collate all of that, and then we will take that stage, we'll go to the health professionals in a group setting and have a look at what's come out of the process so far, what's missing, where is there some really nice alignment between lived experience people, the health professionals, and the requirements that the Ministry of Health has outlined to all the LHDs, and we'll start filling in any of the gaps and start creatively looking for solutions around any areas that are not completely aligned at this point in time. So that all of this feedback loop here helps us prepare for the next round of co-design. So I'm just going to hand across to Carrie now to start talking you through the perspectives and the process that we went through.
Thanks, Bronnie. So yeah, as Bronwyn's described, the process that Roses follows, in particular, this co-design process, is really one that allows and encourages that broad community input, particularly through sort of webinars and feedback loops. But obviously, there are limited numbers of people that can meaningfully participate in these virtual workshops. So we recognise it's important to get, you know, a diversity of professional perspectives and insights in the room, but ones that are particularly relevant to the co-design of an alternative to ED, which is what a safe space is. And so here that has included health professionals working in TAC, which is a triage and assessment centre, the mental health access line, peer workers, people in private practice, youth mental health, NGO Headspace, addiction medicine, and also Aboriginal mental health and older persons mental health. And then what we really focused the conversations around was wanting to understand what it's like really as a health professional to really walk in their shoes on a daily basis, trying to support someone through accessing ED and hospital and TAC in the case of this region when they're in suicidal crisis, what that's like as a health professional, particularly at the different touch points. So people trying to find help, the arrival and initial assessment process, the waiting, treatment, and then also leaving. And so the following slides highlight really the key points of discussion, the key themes that emerged through this first phase of talking to health professionals. And you'll start to see the common themes, and they're animated here with some direct quotes from participants. Thanks, Bronnie.
Thanks, Carrie. So as Carrie said, we were really exploring and looking to understand, you know, what it is like to walk in the shoes of a health professional in the Nepean Blue Mountain regions. So when we talked to when we started listening to stories, and that's really what these sessions were, and it was fantastic to be able to sit and just listen to the stories of health professionals and pull out the key themes, as Carrie was saying, around the different emotions and feelings they have at different stages. So we did a very similar exercise with the lived experience people, and we took them through these very specific touch points of accessing help through ED. So for the health professionals, when we were talking about that time when either someone that they were supporting knew that they were needing some support, that they weren't necessarily able to keep themselves safe, and they needed to access support, what was that like? So it was interesting to hear some health professionals sort of looking back to the way things used to be, and observing that there was this trend over time towards ED becoming the main place to take someone who was suicidal. But there was, you know, the comments around back in the 1990s, that wasn't done. It's almost like we're back to the future. But it's so that there has been this trend over the last couple of decades of moving back towards bringing people who are suicidal into ED. They noted that sometimes family are the ones that bring people in, and that the person necessarily doesn't understand why they're there. It can be a really confronting experience for people that are brought in by a police car. We had people talking to us about a scenario where the police car comes in through a massive roller door, but they're not allowed to get out of the car until the door is closed, and it really they believed it was actually quite an intimidating and frightening experience for the people in distress. There was a genuine dislike that police in uniform are bringing people in, that it just doesn't seem right and not appropriate, and that police are increasingly responding to people in distress, even though, you know, I guess initially that's not what was in their job description, and that there's difficulties in getting and giving information to people at that particular sort of time. Some of the comments that our health professionals made You know, really asking the question, do they have to be in a hospital environment? You know, is this the right place? That, as an example that someone gave is, you know, someone will post on Facebook, I don't know how to live without my lovely wife, something like that. And then the police turn up, knock on the door, wake them up. They've already sort of settled and gone to sleep. But the police arrive and wake them up, and then they're brought into ED. There's that comment there talking about, you know, looking retrospectively, that years ago it really wasn't something that entered into our minds to send someone with suicidality to an ED. There was a question that was brought into the conversation also in that other quote there about a health professional recently had a therapist in the community ask them the question about, well, what do I do if I've got a patient with a serious physical problem, but they don't want to go to ED because they've been to ED before presenting in distress, and they're fearful for how they're actually going to be treated now. And so they're actually avoiding the ED for a physical issue because of their experience when they've actually turned up to the ED looking for support through an emotional crisis situation.
Yeah, but then had a look at the point of arrival and initial assessment, and a really strong theme that emerged here that Bronnie's already spoken about is just that idea that the medical model is just not a good fit for people in emotional pain and distress. So there's a struggle with the idea of triage and assessment for people experiencing suicidality, that it's a process that isn't meaningful in that context. And that the need to assess risk in that sort of biomedical way is unhelpful as well. And just even things like that uniforms and scrubs can be very confronting for people. So all of sort of really the signifiers of a health system and of a system that's set up to address physical health emergencies is just that people understood that is sort of an irreconcilable approach with wanting to provide compassionate care that reduces distress in people. There's also the idea that the system itself requires that people need to justify why they should be let into a service. Then people spoke about the physical structure itself, so the actual environment being problematic, that it's brightly lit. There's a sense of us and them in the design because you've got staff behind glasses, that feeling of a goldfish bowl that people often talk about. You'll hear people talk about that, particularly when they're in an inpatient setting or ED, and that this is still the case apparently with TAC, even though that has been a significant improvement. And also just the fact that there are so many other demands on staff that are trying to assess people. So they're having to assess and manage people who may have been physically aggressive. There's also a lot of concern that in these sort of high demand environments that one person may be negatively impacting another person who's in distress. And then just sort of the fears and concerns for staff themselves around having to deal with people who are very aggressive and in your face, and how overwhelming that can be to be working in that environment. And so here are some of the comments, is that the worst feeling is knowing that people will be met with a triage desk that will require them to justify why they need help. And that people may be so triggered, so people in distress by how they're brought in. So as Bronnie had talked about, that particularly when there's a police response, that they may be in fight or flight mode. So recognising that people sometimes whose distress is already driven by previous experiences of trauma, how that can be further, that distress can be fueled by the process of seeking and receiving help through a traditional clinical system, and how then, of course, that in itself can be re-traumatizing for people. And then a nice comment here from a peer worker saying that it feels good to be able to tell people I know about how they feel through my own lived experience, through that meaningful shared experience, so that there is also these positive aspects that happen within a system that the health professionals were studying, were really telling us is not necessarily the right fit for people in emotional distress.
So then we wanted to talk to our health professionals around what their views on and experiences were with people waiting. And the alignment in emotions and feeling around this is really strong with what the people with lived experience told us. And it's certainly very similar to other areas across the state that we have heard about and listened to so far. You know, talking about it being very frustrating and challenging, that it can be incredibly stressful on staff, where there's a backlog of people and you're really trying hard to get to everybody, knowing that you need to spend a lot more time with people, but you simply don't have the time. You don't have that luxury of time to dedicate to people, and because there's lots of others waiting. Trying to balance the safety of clinicians and participants and just everybody around, because obviously there's people that come into ED with all sorts of needs and in all sorts of moods and states and what have you. So that's always challenging. They recognise that the high security and surveillance can be incredibly scary for people, and you know, talked about the fact that certainly doesn't do anything to help people feel calm and safe, that it can actually, you know, exacerbate people's emotions at the time. The fact that when people come to ED and then get put into a room, quite often that means that they're cut off from normal supports, and mobile phones taken, and so there's this fundamental lack of, or you know, loss of human rights that can occur as well. And when people are experiencing distress, they're kept in the ED, but they're kept in this really chaotic environment, and so that waiting time can be incredibly stressful for the people needing support, but it's equally frustrating and stressful for the health professionals who really wish that they were able to do more for the people who come. Some of the comments here were around, you know, the physicality of ED, the seating, the lighting, the glass, the layout. It all indicates to people that I have no sense of value. That there's so much volume of need that the only thing I could do was to make sure everyone had something to drink and eat. And that was just such a heartfelt comment, that the person who said that was just feeling really quite inadequate, and that was really the only thing that they could do for people. You know, a question about, well, if they've had all their tests, why couldn't they come across this space? It was great to see, you know, some of the health professionals already starting to think, well, what could the intersection be? You know, we know that there doesn't have to be a clinical referral, but you know, a good relationship with ED and a safe space is going to be really important. So it's great to see that those sorts of considerations are being made. And a recognition that a big factor for participants can be the trauma of going to ED and having that control taken away, and that significantly contributes to their distress at the time, but also the fact that they're less likely to reach out for help the next time.
And then we looked at the treatment itself, and we appreciated here that when we talk about treatment, it wouldn't necessarily strictly be about people in ED or TAC receiving treatment there. Sometimes it's about people receiving inpatient treatment. It might be PEC, it might be on a ward, but there was still some general themes that held across all of those contexts. And one was, and this was really palpable, that a health professional talking about really the weight of responsibility and the fear of accountability in a culture now that's very retributive still, and it's a blame sort of focused culture, that what it's like as a health professional when you're making a recommendation for someone, the thinking of the fear of and concern of thinking, what if I've made the wrong decision for someone, particularly when we know the stakes are so high when we're talking about people in suicidal crisis. Also, just talking about the feeling of burnout and a sense of hopelessness, and how that takes a toll on the person, but then also there was a real depth of insight from health professionals around the fact that the way in which then that impacts their capacity to provide the kind of compassionate care that they're wanting to do, and that the service itself as a whole suffers. There's also recognition that there is a real difference between how clinicians build rapport with clients, and someone making the point that people who are in crisis, particularly people that have been through the system, have a very good sense, finely tuned into whether people are being authentic with them, and that is an aspect of treatment where it's so specific to the way in which a clinician might be able to build a relationship as to how good the treatment is. And then also people just talking about the fact that, and this again speaks to the idea of the medical model not being the best fit, that that they would like to, and they know that they're really more beneficial to just be able to spend the time just to sit down and to give the person more time to have a chat, to build that relationship, and a recognition again that peer workers provide a real benefit in the context of people in suicidal crisis by able to share share their lived experience in a meaningful way as a way of creating connections to people. Thanks, Bronnie. And here are some of the quotes. So if people just sat down and gave a person more time, they would be able to pull a lot more out of them. Also, there was a strong emphasis on the idea that people wanted to provide person-centred care, but were constrained by the environments, the demands of the hospital system. We should be looking out for a person's interests above everything. And also just a recognition about, as Bronnie was talking about, that there's just people's rights are being denied, and the fact that health professionals have empathy for that and a recognition of that I wouldn't want to be that person forced against my will to access healthcare that involves meds and serious violations of my human rights. And there was even the perspective of someone saying to us that clinicians wouldn't themselves access ED in the case of their own distress. And then also there is a comment around in TAC, love that in TAC everyone was there, access to all support in the one place in the moment. And I think that's referring to the fact that originally it was a multidisciplinary team approach, although we've been told, and I think we'll touch on this later, that that's actually now shifted to an all nursing staff approach. But please feel free to correct me if I'm wrong. I don't know that I have a perfect understanding of TAC because it's quite a unique model in your region. And then also just this quote around the minute you lose authenticity and understanding, you're just building on an already hostile system. Really it was loud and clear that people wanted to provide, that they were in agreement about that there needs to be person-centred, sort of that rights-based approach to care, compassionate care that really is about the relationship, but how difficult, how constrained people are in the current system to be able to provide that care.
So then we just talked about leaving. You know, when people have come to ED, they've been through their initial assessment, they've waited, they've received some form of treatment, whatever that ended up looking like. And the health professionals just really sharing with us how frustrated they were that the care that they gave, it could have been so much more comprehensive. They recognise too that, you know, sometimes they do find something that can just connect, and, you know, if they get that time just to have a conversation, that they can sometimes find something that helps the participant or the person understand the situation that they're currently experiencing. They also realise that some people just aren't coping with things in their life, but being able to go to hospital helps them just to have a little bit of a break from whatever it is that they've walked away from. But, you know, at the same time, comments around the place that they're coming for a little bit of respite is not necessarily the ideal place. The ward is perceived by many of the health professionals as the last resort for people. So there were a number of health professionals that spoke to us about doing whatever they could to prevent somebody needing to go onto the ward. Another was that I like being able to offer services to people that wouldn't otherwise be able to access them. So there is that level of satisfaction about being able to provide a service that for some people is meeting their needs. And that goes with that next comment there, and that there are good private services, but not everyone has the ability to access those. Some of the comments around from the health professionals, due to burnout, people may just default to churn and here's some meds, get out. It's a pretty strong statement, I think, and it's something that we hear of all the time. The level of burnout amongst our health professionals is really concerning. People have this perception that going to hospital will fix everything, but I know that's not the case. What we can do is provide someone with a safe environment. They're talking about trying to be realistic about what they can achieve within the system that they have to work within, and that needing to, I guess, be kind to themselves in a sense and realise that they are having to work within a system, and there is only so much they can do within those boundaries. But also a recognition that taking a person-centric approach might mean that they don't even need to go to a hospital at all. And from the discussions, it sounds like there's quite a strong belief that in many cases that would be a preferable outcome. So generally speaking, when we just sort of said, look, what's your general feeling? What are those couple of things that really come to mind just from an overall perception of how it's working? They were uncertain that people have a choice in the support that they receive, and that people ought to have a choice. Supporting grassroots community-based mental health services is happening with good outcomes. So that was really promising to hear, that there are some great community-based mental health services in your region. Needing to demonstrate efficiency is, I think, a challenge from what we're hearing. But there was there was a lot of positive things said about TAC, and I think that's really important to note here, that the region does have this particular service. Some people that we've spoken to working within it absolutely were able to explain how it differs from ED, and yet they could still see areas for improvement as well, and how a safe space could intersect with that. People have this perception, I think we had that quote before, people having this perception that going to hospital will fix everything, but knowing that that's not the case is kind of frustrating. And even if a system is there to support someone, if you have one bad staff member, and this is a quote, it's not us saying this, that can ruin the experience for a participant. So I think it's more, in the sense that it's in recognition that there will be, a whole heap of pressures on health professionals at any given time, but you kind of have one chance with someone when they're in that distressed state, and that, as Carrie said before, really tune into authenticity and what have you, and that just the opportunity to connect with that person, if it goes wrong the first time, that can turn into a really bad experience for the person. And if the person's at the centre, I feel like we can all work together. So really talking to that real desire to be able to provide that person-centred care.
And I think we've sort of covered this to some degree, but we just wanted to acknowledge that these safe spaces that are rolling out in every LHD in the state, that it's really about this local co-design process, that it's not a one-size-fits-all. And in this region, what is particularly unique is the fact that there's already been an acknowledgement of the need for an alternative to ED for people in high levels of emotional and mental distress. And so TAC, this is this is some of the general feedback about that, about the establishment of TAC and where it is now. So the feedback is here that clients say overall it's much better than going to ED. Staff say that it feels good to offer people an experience they usually wouldn't get within the public health system, and that it's something people can access quite easily and speak to someone quite easily. But also that, and I think I'd mentioned this, that it was originally set up as a multidisciplinary model, but has since shifted to a nursing only model in terms of the clinical aspect of it. And that people have said to us that the capacity to deliver compassionate, person-centred care is still very much constrained in the same way that any other aspect of the public health system is, by a medical risk-averse culture, and just the demands, the reality of the demands of a high-pressure, often very resource-scarce environment in the health system. And also we were told that there's just been the double, that it was set up to meet the demands of, I think it was estimated 300 people a month. Is that right, Bronnie? And that it's now, that's already doubled in terms of what was planned for and resourced for. So we all know the problems that come from that.
Yes, so then we wanted to know, you know, what from a health professional's perspective, what's needed, and a couple of key questions that we had for them. So firstly, we wanted to know what's missing from the services that are already available in the Nepean Blue Mountain region. And, you know, you can see a number of points there. Safer assessment processes, availability of community crisis services, access to a service that involves peer workers and clinicians, so a blended model. After hours, of course, looking for services that are available outside normal working hours, and looking for the availability of flexible service models to meet the really broad needs of people that are experiencing suicidal crisis. You know, recognising that people arrive at a point of experiencing suicidal crisis from a whole range of underlying factors and reasons. They talked about clinical capability, crisis management, and involvement of peer workers within inpatient wards. Access to coordinated service responses that link people, so that real connection that goes on, tapping into those great community services that we were told about that do exist within the region. And just a greater awareness of what's actually available in the community, and soft entry points to understand needs and access other services. You know, we were told about the B&Co services that are available, and so it sounds like there's quite a lot in the region, but potentially there is scope to an opportunity to connect those a bit better and have greater awareness of those.
And then we wanted to get people's views on what, from a health professional perspective, what do you need to feel comfortable and confident to support people to access a safe space in the local region, recognising that there is actually in the ministry requirements that there's no requirement for a formal referral pathway in or out of the safe space, and particularly there's no referral pathway from ED. And so what would encourage health professionals to recommend it, and also to just be champions of an alternative, a new kind of community-based support. And we know that it's really important in local regions for health professionals particularly to be able to champion this sort of new way of working, this new approach to supporting people. And one was this sort of sense of a genuine collaboration between peer workers and clinicians. Now, as a non-clinical model, it doesn't require clinicians in the space, but there's also that idea more broadly that there's a collaborative approach, and that also may include peer workers being able to support people to an ED, for example. And just for people to have a clear understanding of the safe space model of care and the services offered, so they can say to people, if you go to the safe space, this is what to expect, this is what you might be able to access. You know, if there's a program of activities, for example, and there's a strong sense that there needs to be very clear understanding of the governance structures, and that there are, certainly in the ministry requirements, they talk about the robust governance structures that will be embedded, but that they don't need to be clinical. It doesn't need to be clinical governance. So people, totally understandably, health professionals want to know what that looks like. And also importantly, very similarly to people with lived experience, confidence that the safe space enables choice and respects participants' wishes, and that there's an empathetic, and I liked this, open-hearted approach. So that this aligns very much with what people with lived experience were telling us also. There's that flexibility with opening hours, and also a location that doesn't have a view of the ED. So recognition that that can in itself be quite traumatizing. So part of what cultural safety means in terms of a safe space also means that people are not, that the safe space isn't in view of the emergency department. And then just again, this idea of a clear and transparent sort of mechanism that's in place that everyone understands, so they have a shared understanding of what happens when, in traditional clinical language, it's called an escalation process, but just that, I guess the experience where someone might identify for themselves that they need more intensive supports, or that they might want clinical services, and what is the process there. Also culturally appropriate service responses. So we had a couple of people in the room particularly talking about in terms of supporting Aboriginal people and communities to access these services. So needing to feel confident that these are culturally, that people working there have cultural competence, and also that they're culturally appropriate and safe services. And then also concern around the need to make sure that peer workers are safe in their practice, and also that they're appropriately supervised, or that they have the capacity for some form of mentoring. So that is actually being developed, and the ministry has guidance documents around what they're calling the SP peer workforce, and opportunities for debriefing. And also health professionals were wanting to know sort of that collaborative aspect of this model of care. So how are family and friends, how do people, loved ones are included, and how are they given information about the model and what to expect? And again, I think I'd already touched on this transparency of the pathways to and from the safe space, in recognition that there isn't a formal referral pathway, but what are those sort of partnerships look like with other services? Thanks, Bronnie.
All right, so we're going to hand back to you in just a moment to see if anyone's got some questions. Before we do that, there's a website link there. If you want to watch this recording again, but more importantly, I think send it on to other health professionals in your networks, because we really would like some additional feedback. Send it as far and wide as you can. There'll also be the survey for you to complete if you'd like to add anything more after you've had some time to reflect on the sessions that you've had with us, or once again, the survey for more people. You can go to the Roses in the Ocean website at rosesintheocean.com.au/Nepean Blue Mountains LHD. So we will now stop sharing screen and come back and have a look in the chat room to see. Right, so a couple of questions. I think more a comment here. The person is triaged, assessed and reviewed endlessly, and each new clinician takes the person's often traumatic and triggering to tell story and hands over to the next clinician. There is no sense that people have arrived somewhere where the person I'm talking to is actually going to help them. The overall sense is often, you're not that bad, go away, go see your GP for a referral to a psychiatrist. That's a comment from one of our health professionals. And again, can TAC move from a medical model to a peer model, run and staffed by at least 50% peer workforce 24/7? So a suggestion there in terms of how a blended model might be able to move into that space. Thank you for those comments, and we will be able to we'll make sure that we copy those and capture those as well. But
and I think that comment around the blended model for someone suggesting that about a blended model in TAC, they're the sort of ideas that we're also wanting to capture here. We've found in other co-design processes that while all the best and brightest ideas may not also all be able to be realized within the safe space, for example, of the service that you're co-designing, these really do help. We feed them back and it helps to inform the thinking about service improvement in other contexts. So it's super important.
So does anyone else have any questions for us before we let you get on with your day?
So someone said, will everyone who works in the safe space have access to training for trauma-informed care? And certainly the ministry requirements is that trauma-informed care is provided in the safe space. Obviously, we need to know what that looks like. Trauma-informed care has become one of those buzzwords like recovery-oriented practice. And so it's, I think what's really important about this process is that we have started to the people with lived experience that are participating have drafted a set of core values and guiding principles that are going to be refined, and that those things are things that really make those terms like trauma-informed care actually meaningful. What does that look like in practice? So, yes.
And I encourage you to look at the ministry's requirement documents. They are soon to be released. I know they're at, I believe they're at the graphic designers or what have you, but they very clearly outline really comprehensive training that's going to be expected to be given to the suicide prevention peer workforce. And so it's good to have a look at those guidelines. The LHD will obviously be looking at those. The mental health access line is run by Medibank. I'm from the Blue Mountains Mental Health Access Team. We provide assessment and short-term follow-up for people with suicidal behaviour in the community. That's from Ross Jamison.
And then also here, Madeleine has said that she's found in previous roles that clients coming in with a disability, the treatment wasn't as collaborative as people that aren't living with a disability. Is this something that would change, and will further training be required for peer workers around clients living with disabilities and how to better support those clients and staff who may come into the service? That's an excellent point. We do know that people living with disabilities are at higher risk of suicide and suicidality and being in crisis and distress. So it's an excellent point, that idea of making sure that people are able to, that the safe space is an inclusive space. And that was one of the things that came through loud and clear with lived experience participants already, that sense of inclusivity that would also include, you know, the need to provide support that takes into account those other aspects of people's identities.
Is there anything else there? I'm just making sure I'm copying these comments that come through so that we don't lose them. All right, look, that looks like it's all for now. So thank you all so much for those of you who've tuned in. Thank you very much for joining us today. For those who have joined us that participated in those focus conversations, thank you also. As I say, please, we'll get this live webinar up for you this afternoon or tomorrow, and then the survey will be there as well. It'll be open for about a week. The closing dates and everything will be written on our landing page for your LHD on our website. So take care. Thank you for your time, and we'll talk to you soon. Bye.